So thank you very much. And my aim, as Dr. Sabni said, will be to contaminate all of you with my passion for supine PCNL. So even though we are talking about supine PCNL since many years, in reality, supine position has been included in the guidelines of EAU for the first time only in 2012. Before this, no mention about this position. And look at that, already the first time there was already written that the advantage of the position were shorter operating time, possibility of simultaneous manipulation, more convenient position for the operator, and easier anesthesiological management, which are already good reason to be tempted to change the position. But supine position is much older than this, because as you can see in this picture, this is Dr. Valdivia, the real pioneer of supine PCNL, that he described the first case in 1987. And look at that, already in 1990, he published this paper on Journal of Urology with this very provocative title, Why PCNL is Still Performed with the Patient Prone. And 1998, 22 years ago, he published on Journal of Urology the series of more than 500 cases in which he was already able to demonstrate that basically he could achieve the same outcomes in this new innovative position, which is supposed to be much easier to carry out. Honestly, with supine position, we don't have only advantages. We have also some disadvantages. And one of the aims of this lecture will be to share with you some tips and tricks in order to overcome these shortcomings when you're gonna meet them in the OR. So let's go back to the history of PCNL. Why PCNL has been developed with the patient prone? Was it a mistake? No, it was not, because at that time, we are talking about beginning of 80s, there was no CT scan nor ultrasound. So basically, they didn't know where the colon was. So they didn't know what was in between the skin and the kidney. So for sure, the more posterior you do your puncture, the safer will be your access. That was the reason for prone position. But with the advent of CT scan and ultrasound, things have changed. So if you look at this picture, of course, if you have a case of retrorenal colon, like in this case, you see completely retrorenal colon on both sides. These sides, this is for sure not an ideal case for supine PCNL. But as reported in this paper on radiology back in 1987, look at that. Retrorenal colon is present in 2% of patients in supine, while it's present up to 10% in prone. I'm sure that not so many urologists read this paper at that time, meaning that the majority of our patients, they have the colon far away from the trajectory of our PCNL. Look at this, these are normal cases in which the colon is clearly far away. And this has also been demonstrated by Dr. Valdia. These are historical pictures given to me by my mentor for supine. And as you can see in this cadaveric study, on the picture on the right, you see that our access in supine PCNL is sufficiently below the reflection of the peritoneum, which is supposed to be at the level of posterior axillary line, which is our most important landmark. That's why I always suggest you to draw this line on the patient's skin. So prone position has some advantages. For sure, operative field is wider in prone because you have all the back draped, so you have more room to identify the better direction for your needle to puncture the kidney. As you can see in supine position, the window for our puncture is much more limited. This is the original Valdivia position, which I changed a little bit. I will show you later on. But basically, as you can see, these are the landmarks which we have to refer to. Posterior axillary line, 12 rib, and iliac crest. And as you can see, the window is very limited. Keeping this in mind, this other gentleman from Spain, Gaspar Ibarlucea, was the first to have this intuition to manipulate the patient in both ways together, PCNL and flexible ureteroscopy. And he invented this position. The name is Galdacca position, because at that time, Dr. Barusel was working in Galdacca Hospital in Bilbao. Basically, the position is the same, only the legs are put on the stirrup, so there is a second, another place for a second surgeon to perform a simultaneous flexible ureteroscopy. This concept then has been evolved by my Italian friend Cesare Scofone, that he codified this international acronym, HIS, which is a systematic integration of flexible ureteroscopy and PCNL in all cases, endoscopic combined infrarenal surgery. Honestly, I like this procedure very much. My concept is a little bit different from the one of Cesare. I do HS only when it is really needed. Otherwise, don't forget that you can do a lot of things also with your flexible nephroscope introduced by your ampla sheet through the flank. When it is needed, basically when you have stones in parallel calyx, so that you cannot overcome this steep angle with your flexible cystoscope introduced through your ampla sheet. Of course, you can do combined also in prone, as some American colleagues are saying, but it is quite intuitive that it is much more difficult. Honestly, you know that the first HS has been performed in 1993 by Dr. Grasso in prone position. But it was so easy that basically nobody has performed this surgery for the following 20 years, because it was really much, much more difficult. Now I want to drive your attention to this paper, which I really like. I still like a lot with my friend Mario Soffer from Israel. You know, Mario, in the beginning was a real enemy of supine PCNL, but 7-8 years ago, he asked me, may I come to Milano to see some supine? He came, and you know what? It was love at first sight. He shifted completely to supine PCNL, and he was the first to have this intuition. Since the puncture is much more lateral in supine, you see that the angle between the lower calyx and the upper one is much wider when compared to prone, meaning that in the vast majority of cases, through a lower pole axis, you can reach the upper calyx, and this with a rigid scope. And this is particularly useful when you perform mini-per. Look at the discrepancy is 80% in supine versus only 20% in prone. And actually, honestly, we feel so comfortable that also in bilateral PCNL, we still perform supine position, which is a little bit counterproductive, because in prone, you drive the patient only once. Instead, in supine, you have to change the position. But the time that you waste by changing the position is the time that you have already saved by not flipping the patient in the beginning. And last evolution, thanks to the supine position, is this kind of surgery that we perform for the first time at our center. The name is SEBES, simultaneous bilateral surgery, that thanks to this position, sometimes in case of bilateral stone, we perform in simultaneously, that means in tandem, PCNL and flexible ureteroscopy on the other side. And this was published on European Urology 2 years ago. And if you like to watch this surgery, it's easy to download the video for free because it is included in the Surgery in Motion on European Urology. So supine position is more ergonomic, but also safer, because the surgeon during the puncture does not receive radiation directly on his hands. Instead, when you perform prone PCNL, most of the time you have your hands under X-rays beam. Look, this was funny. During a meeting in Brazil, I was criticized a little bit for this previous slide, but when this gentleman, my friend Norberto Bernardo, performed this surgery in Sao Paulo, I recorded that his hands were visible on the monitor for more than 7 minutes during the puncture. You see, instead they never saw my hands, just because my hands are lateral. Another little detail in favor of supine position is that during the surgery, you don't have to move the C-arm back and forth to avoid conflict of your nephroscope. As you can see in this running video, you see that in supine, you never change the orientation of the C-arm just because there is no conflict. By the way, this was one of the few cases, basically 3 out of 3,000 PCNL, in which I had to go back to prone position. It was a very difficult steg on stone, and as you can see, due to this paraspinal orientation of this calyx, I had to go back to prone, meaning that if it is needed, I still go back to prone, but it has happened only 3 times out of 3,000 PCNL. These are my numbers. So now let's focus on the position. This is the original Valdivia position, and most of the surgeons are still adopting this. 3-liter saline bag under the flank and the landmark, as I told you before. Sorry, why is not? Sorry. Okay, so this is the original Valdivia position. And then since I had some problem with this bending of the patient over the saline bag and conflict with my nephroscope, traveling around the world, I changed the position. You see, so the water bag was under the shoulder and the jelly buster under the gluteus. I was very proud of this picture at that time, but now I can tell you, it is clear that at that moment, I was still on my learning curve. You know why? Because the inclination of the patient is too much. This is a mistake. Provided that there is no column in between, don't do this mistake to rotate the patient too much. The less you rotate the patient, the easier will be your puncture. Because according to this drawing, you see, we don't need a significant inclination. Only 15 to 20 degrees usually are more than enough to reach the posterior lower calyx that usually is our access to the kidney. So this is my position actually. You see that I don't use the water bag anymore, but I use this swimming noodle all along the flank. And as you can see, the rotation is very, very mild. This is for normal PCNL, but the position is the same. Also, in case of endoscopic combined intrarenal surgery, you see again the swimming noodle, but only the legs on the stirrup. And now you will see the position that I developed just last year with my coworkers. Because in the beginning, sometimes I had some problem of conflict of my rigid nephroscope against this metallic support. That's why we change, and actually this is our position. You see, we keep half of the operating bed on the stone side and the stirrup only on the contralateral side. So that if I have to do this movement to reach the upper calyx, it is very easy and no conflict anymore with the operating bed. So you see that positioning is very fast. After the end of the intubation, to place the patient in position is very, very easy. 1 doctor, 2 nurses, and believe me, it is a matter of a few minutes. And I don't have historical picture about my prone era, but this was a picture that I took some years ago in the Netherlands, and look at that, 8 people cooperated to flip this gentleman, not only 3 like I showed you in supine. And also draping of the patient is another advantage because we have a single draping from the beginning till the end of the procedure because we don't have to flip the patient. So basically this is the phase, the step in which we save so much time just because we drape the patient once and we don't flip the patient. So basically from the hand of intubation till inside the kidney is more or less 10 minutes. And if it is an advantage for normal patient, try to imagine for such a big patient like this lady. We are lucky enough not to have so many in Italy. This lady is my personal record. She was 250 kilos, but they are very anecdotal in Italy. But I have this historical picture when I was fellow with Dr. Clement in St. Louis. Try to imagine how painful it was to flip this gentleman. It took, I remember, something like 1 hour and a half, 2 hours. So this is an important point. Basically, according to this paper from another Italian group, it is the only randomized study. I agree completely with this study. Outcomes are the same because basically procedure is the same. It's only easier way to do the same surgery and faster, because we save more or less half an hour just because we avoid to flip the patient. We can skip this paper. From an anesthesiological point of view, I think that I don't have to use many time to convince you that it is really an advantage, because anesthesiologists, of course, they appreciate a lot the fact to have the patient supine instead of intubated in prone position. So the ergonomics is clearly in favor of supine, much easier, faster, less labor for our personnel, single draping, and it is really much appreciated by your anesthesiologists and nurses. So my suggestion is to hurry up to shift to supine, otherwise you will have to deal with some strikes in your hospital, because for sure the painful maneuver of flipping the patient is not really appreciated by the nurse team usually. So now another little practical detail. In theory, it would be ideal to place the patient just on the edge of the operating bed. Remember that you cannot do this because the last 6 centimeters of the operating bed, there is this metallic bar. So remember to keep the patient a little bit, 3 fingers inside. Because if you don't respect this concept, remember that you will realize immediately, because the metallic bar will be over the kidney and your puncture will become impossible. Now let's focus on the puncture. A good puncture in supine is the same as in prone, so it should be supposed to be transpapillary. The puncture is much easier in supine because each tray are perpendicular to your needle. It is not like in prone, in which there is an acute angle. So what we see on the X-ray monitor in supine is a real advancement of the needle when compared to prone, in which it is, let's say, a projection of the advancement of the needle. So now I show you my technique with triangulation. I always start with the C-arm at 0 degree. So I start to target my calyx in 2 dimensions. And you see, when you see the kidney moving under the action of my needle, usually I am in the correct plane. And believe me, most of the time, I enter the kidney at a very fast effort. Another advantage is that in supine, if you are in, you will have automatic dropping out of the urine. You don't have to do suction. Sometimes you do this wonderful puncture, you open the needle, you don't have urine coming out. It means that you are missing the depth. So you have to do triangulation. So you tilt the C-arm 30 degrees toward the head of the patient. If by doing this, your needle will move below the calyx, it means that your puncture has gone too anterior. So you have to retrieve your needle, to raise the needle up, and to go back in. Vice versa, if by tilting your C-arm, your needle will move above, it means that your puncture has gone too posterior. So you have to remove the needle, to raise the needle up, and to go back in. Believe me, it's very easy and precise. Now I share with you this video that I recorded during a course that I usually, unfortunately, is not running. Okay, so this is in real time. You see, I target below the posterior axillary line. Look, I'm not moving the kidney, so I'm not in a good position. That's why I ask my nurse to rotate the C-arm 30 degrees toward the head of the patient. You see, and by doing this, you will see that my needle is clearly very, very below. So my puncture was too much anterior. So that's why I ask my nurse to go back. I retrieve my needle and I inclinate the needle down. Unfortunately, this video is not, maybe because the video is too heavy. It's not running, unfortunately. But anyway, it was just to show you the triangulation. So remember, is the opposite. If it is below during tilting, our puncture is too anterior. Vice versa, if it is above, it is too posterior, like it was in prone, honestly. Then, of course, even though I am not a good user, another solution is to use ultrasound. And ultrasound, of course, can overcome all these limitations because the advantage of ultrasound is that you can detect very easily the depth of your puncture. And of course, you can also detect organs that lie in between the skin and the kidney. Well, another fake news that sometimes we hear during the congresses is that in supine position it's not possible to approach the upper part. It's not true. For sure, I prefer to go through the upper calyx, but through the lower calyx. But if the stone, the majority of the stone is in the upper calyx like this, usually is not a big deal also to approach the upper calyx like I did in this video. Look at this. There was this staghorn stone in only the upper calyx. I did my puncture. In supine, it is only much more lateral, but as you can see, with this stepwise approach, because I wasn't able to make the guide wire go down in the ureter, so I did a mini per access. I break just a little bit the stone, and as soon as I was able to negotiate the infundibulum of the upper calyx, as you can see, I was able to make the guide wire go down in the ureter, and at this time, I could increase the diameter of my access to a standard mini perk so that I could clean this patient completely. And it was a supracostal access, and nothing happened like when you do a good upper pole access in prone. Also, multi-track procedure is not a big deal, of course, and my little trick is when you have difficult cases, a staghorn stone, remember to place all the guide wires before performing all the accesses. Sorry, it's stuck. Okay, so this is another interesting video. This is maybe the most important drawback for supine PCNL is the hypermobility of the kidney. Unfortunately, also this video is not running, but as you can see, only under the action of the needle, I make the kidney rotate on its axis as it is seen in this animation. Because of course, in supine, you push the kidney against the abdominal wall, which is floppy, instead against the operating bed, which is hard. So, sorry, it's not working anymore. Give me. We have some problem with the videos because maybe they are too heavy. Okay, sorry. Come on. Sorry. Okay. So when I have this problem of hypermobility, my trick is to put my left hand on the belly of the patient and to do a kind of contrapressure just to stabilize the kidney. Okay, we can, when you have to do the dilation, you can use whichever method you prefer. I can set of the telephone dilator, but my favorite one is to use balloon, but it's up to you. This is not a big deal. It's like in prone PCNL. And same is for lithotripsy. Now I like very much my trilogy from EMS, but also Olympus shock pulse is a very effective way to do lithotripsy. So the pass the ball technique is the quintessence of a supine PCNL. As you can see, this is a real integration of flexible ureteroscopy going in a parallel calyx with nephroscopy. You see, this is pass the ball. or better, this is the stone, pass the stone. We are not talking about soccer. And as you can see in this case, my colleague Silvio Proietti was able to pass me the ball, and so that we were able to render this patient stone-free without doing a second access. So multiple accesses actually are much, much less than in the past. Again, another trick for a good pass the ball technique, but I think that it's better to skip because also this video is very heavy. We can skip this. Sorry for this technical issue. Okay, so other advantages is that the surgeon can operate comfortably sitting down on a chair. You know that the Italians are a little bit lazy, so I prefer to be comfortable in the OR. And of course, we have also spontaneous evacuation of fragment throughout the entire surgery. Another advantage is that it is very easy to place the stent retrograde in retrograde fashion when you do tubeless PCNL. And look at that. This is another bad disadvantages of supine, that sometimes the surgeon, specifically myself, get wet after the surgery on his leg. That's why I suggest you to wear something in nylon just to protect yourself. So in conclusion, I would say that the rationale for doing PCNL only in prone position has been demonstrated not to be completely correct. Supine PCNL offers several other advantages. So I don't see actually contraindication to consider supine position the position of choice. Nevertheless, if you don't like it and you want to keep on performing prone, it's not a problem, it's not a shame. But I would say that since it is an easier way to do the same procedure, I would say why not? And for sure, it is advisable that a young colleague should be familiar with the position. That being said, 80% of PCNL are still performing with the patient prone. Why? Well, a lot of surgeons are not very young, like Ernest Hemingway in this picture. When you are not very young, your motivation to change is not so strong. But I'm quite sure that when doctors like this gentleman will coming from 30 years of prone PCNL done in this way will be slowly replaced by younger colleagues, I'm quite sure that to find a prone PCNL will be reported only in the pictures in our offices, but not in the OR anymore. And if you don't trust me, trust this gentleman. This is the European godfather of PCNL, Dr. Alken, that in the beginning was against the position, but some years ago, he wrote this sentence: Prones was just a mistake, but hard to eliminate until today. So, doctors, I'm quite convinced that we are going to replicate what has already happened in the athletics. The first time that Dick Fosbury jumped with the supine technique, everybody laughed at him. But after he won the Olympic Games in Mexico City back in 1968, establishing the new world record, everybody started to laugh against Vladimir Yaroshenko, the previous world record holder. And you will see that we are going to do the same in endourology. So I hope to have been successful in contaminate all of you and mimicking the great Mahatma Gandhi. And if we consider the Mahatma Gandhi, let's say our Dr. Valdivia, the Mahatma Gandhi of supine PCNL, he had the strong duty to take the first two steps when everybody were ignoring us and they were laughing at us. Then I took over. And again, I took the third step when everybody were fighting me. And now the last challenge is to take the fourth last step, that is to win. And I hope that I will be able to do so, to contaminate, apart from a lot of American, also European, also a lot of Indian friends that will be, and I will be very happy to see the dissemination of supine PCNL also in your wonderful country. Thank you very much for your attention.